So for today, I'm going to go over the basics for anyone new in the room about adrenal insufficiency with ALD. And I'll talk a little bit about surveillance as it stands now for adrenal insufficiency. And then I'm going to discuss treatment. And then at the end, I'll touch a little bit about testicular dysfunction, which is sometimes missed in the discussion. So what is the adrenal gland? So this is our picture, and very simplified so that you understand. ACTH, and I don't know, does my pointer work? Yep, perfect. Okay, so your pituitary gland is making ACTH, which turns on your adrenal gland to make cortisol. I'll get to what cortisol does in a minute. And when there's enough cortisol around, there's a negative feedback loop to bring that ACTH back down. This is important as we're kind of going through all of the tests here in a minute. Cortisol has a really important function in our body. It gets released with a circadian rhythm. For anyone who has an infant in the room, circadian rhythms are based on your sleep and wake patterns and your eating patterns. And if you have an infant, they don't have it. So we'll talk about what that means with an infant in a minute. But normally, for those of us who don't have infants in the room, you're going to bed at normal hours, like 10, 11 at night. Your cortisol levels get lowest around midnight to 2 a.m. Then they start to rise, and they usually peak right around 8 o'clock in the morning. Cortisol is really important for maintaining your blood sugars in times of stress. It's really important for maintaining your blood pressures in times of stress, basically getting all the fuel that your brain and your heart needs. And normally during the day, you're just kind of using a little bit of cortisol, so peaks in the morning and then kind of trends down towards the night. So what happens with ALD? Those very long chain fatty acids that are getting detected on the newborn screen are elevated, and they start to accumulate in the adrenal gland. And in the cortex of the adrenal gland, you're making this cortisol. The cortex also makes androgens, and it also makes mineralocorticoids, which regulate salt. And we'll talk about those in a little bit as well. And this is my picture that I've stolen from an endocrine textbook of the adrenal cortex. So there are 3 zones, and each zone roughly makes the different hormones that are important for the adrenal function. The glucocorticoids, which are the cortisol, and I lost my marker, there it is, are the cortisol. And that, again, is important for your blood sugar, your blood pressure, particularly during times of stress. So these very long chain fatty acids get integrated into the adrenal cortex, primarily into the 2 zones that make cortisol and the androgens, and interfere with the production of those. They also will get into the other zone, the glomerulosa zone, and cause problems with how you hold on to salt, but that's not quite as common as the others. And we'll talk about the typical progression in a few minutes. So in terms of how does this work, why do those very long chain fatty acids cause problems in the adrenal cortex? There are 2 primary thoughts about this. One is that they just cause problems with how the cells function. They make the cells not work at all, and the cells break up. The other possibility is that you have the very long chain fatty acids getting stuck inside the cell membrane and causing problems with how the ACTH, that hormone that turns on the adrenal gland, binds to its receptor, and so then you're not making cortisol. And so what ends up happening is you're not making enough cortisol, and then there's a lack of negative feedback, and so then ACTH levels go up. And what does this look like in real life? So if you have adrenal insufficiency in real life, you're going to have, in a young child, it may be difficult to pick up, but often they won't eat well, they won't gain weight well, they'll be a little more tired, a little more sleepy. They'll complain if they're a little older, they'll complain of belly aches. And classically on physical exam, you'll see that the skin is getting darker, and particularly in areas where there are creases or scars, the back of the ears and genital areas like nipples and nipples as well. In those who develop problems with how they make mineralocorticoid, they will be losing salt in their urine, and so they'll also be looking for salty foods and licking a pretzel stick and tossing it aside, or taking the salt shaker and just kind of dumping it onto their food. Acutely, like when someone is sick with adrenal insufficiency, they can get really, really sick. And so you can have low blood sugar, low blood pressure, they can have altered mental status, and they can have vomiting, and ultimately this can be life-threatening if not managed and treated. So it's important to be able to identify. This is just a picture of relatives that you can see, the darkening of the skin, the classic areas that you find it on the knuckles, palms, soles, nipples, and in the gums and in the mouth. So what do we know about ALD? And we'll try to go through a few of the bigger studies that we have for adrenal insufficiency with ALD very quickly, but roughly 80%, 86% of boys who have ALD will go on to develop adrenal insufficiency. The earliest biochemical report is 5 weeks of age. Females with ALD are reported to have an incidence of adrenal insufficiency of less than 1%. And diagnostic very long-chain fatty acids have not been correlated to predicting adrenal insufficiency. And I'm going to get to the gray zone in a little bit for a very recent report. So I've talked about this one, a couple of these studies a few times now. So I'm going to try to go through pretty quickly, but there basically are two big adrenal insufficiency studies for ALD. One is prospective and was before the era of newborn screening. And so these were families who had known family members with ALD who were included in the study. It was done at Kennedy Krieger. They had 49 boys who were enrolled. They were all relatively young in the study. And what's important to note is that at baseline, at enrollment, when they were supposedly asymptomatic, roughly half of them actually had adrenal insufficiency at the time that they got screened. And then another third had these borderline results. And by the end of the study, which was only on average, follow-up was only a couple of years, they identified 86 boys who had adrenal insufficiency. The other study is a natural history study, which was a combination of the Netherlands and MGH groups. They had 159 males. They had an older cohort. And the definition of adrenal insufficiency in this group, some of it was based on laboratory testing, some of it was based on patients already coming in on hydrocortisone treatment. And in this group, as I said, it was older, the average age was 24 years, and they found that 80% of the males in their clinic had been identified as having adrenal insufficiency, and the youngest in their cohort was 7 months old. What's important from this study is to point out that about 2/3 were actually symptomatic when they were identified as having adrenal insufficiency. So they could have had a crisis when this happened, meaning that they came in.
You've been in that network then.
Okay. It means that they could have presented with a crisis. The other thing to point out is that there was a significant lag in diagnostic delay based on symptoms. And all the way, if you see the arrow that I have there, there was someone in their cohort that it took 21 years to diagnose. Like, this is someone who had been having recurrent symptoms, and that's not unusual. In my office, when I have had people who were not picked up on newborn screening, to have them say, oh, every time he got sick, everyone in the house got the flu, but he was a kid who took 5 days to get better from the flu. Or he was the kid in the emergency room who needed IV fluids with the flu, but the other siblings didn't. More than half of the patients in this cohort were treated with mineralocorticoids. So we know that salt wasting does happen, but it doesn't happen, it has not been reported to happen in isolation. So the glucocorticoid, the cortisol deficiency presents first, and then the mineralocorticoid deficiency. And in this group, they did not have any correlations with very long-chain fatty acids and the onset of adrenal insufficiency. And this is just one of the graphs from the publication, but it just shows that the median time until adrenal insufficiency developed seemed to be about 14 years, although, again, there was that diagnostic delay of symptoms and when people got started on treatment, and it was about 2 years in that delay. The average age for mineralocorticoid treatment was much later, though, into the 50s. So what do we do for monitoring, and how do we figure this out? So I always like to show this picture because this was our very first meeting, and I think meetings like this are really important because it brings people together. And somewhere in this, you'll see me and you'll see Rose Marino. And there were two endocrinologists in the room, and we said, geez, we have no idea when and how often and what we're supposed to be doing. And so we got a group together with the Pediatric Endocrine Society, and we came up with initial guidelines. And I want to emphasize initial, and it's really based on our best clinical practice. So in medicine, we like to have evidence-based guidelines where we actually have studies and we have long-term follow-up, but because newborn screening is so new, and because, as I just pointed out, it can take years for adrenal insufficiency to develop, we decided that we needed to at least have a starting point for where we all should be and then revisit. And we'll talk about the revisiting here in a minute. So the approach to the positive newborn screen, what do we do? Once the newborn screen a team or metabolic team has confirmed the diagnosis, my personal goal is to try to see the families within a week. I'm fortunate to be in New York and have had this. I was saying yesterday to have had the experience of taking care of newborn screening patients now for over a decade. But part of the reason for that initial see within a week is because you want to make sure you're not missing other family members who need to be identified and treated, not because the babies that come in are typically asymptomatic, at least in experiences that we've had. So my personal approach, see them in the first week, get a good family history, identify anyone who needs to have adrenal testing in the family, a physical exam, looking for signs, symptoms of adrenal insufficiency, but then also teaching the families what adrenal insufficiency is, what it looks like, and making sure that they know when to call you if they have any concerns. There's a lot of great education. ALD Alliance has a wonderful handout for parents, and it's part of the guide or the care package that goes out to families. And I would encourage everyone to take advantage of it because I think it's written in a language that parents can understand. So what do we do when those babies come in? When do we think about screening? So as I mentioned before, infants do not have that circadian rhythm, which means they don't have a predictable time that their cortisol levels are going to be at their highest. On top of that, we do not have really good reference ranges for babies or toddlers, anyone under the age of 3, for ACTH. And then in addition to everything I have on here, with babies having lower cortisol levels just at baseline because they don't have as much stress, and they also just do not have, really newborn babies do not have high binding proteins for the cortisol, which is what helps you measure cortisol in the assays. In addition to all of this, we have recently changed cortisol assays. Most institutions across the country are now using more specific assays that are detecting that have less interference, and so most cortisol levels have dropped since we have written the new guideline, or the guidelines that were published, I should say, in 2019. The other problem is knowing when to start treatment. So when to start screening. And for the most part, I think that in the first couple of years, because it's so difficult to diagnose, that screening more frequently it is important, and to understand what the patterns are, but also to make sure you're not missing an infant who may be a little more difficult because they can't tell you that they have stomach aches, or it's hard to tell sleep patterns at that age. As kids get older, you can start figuring that out. And I think that makes it easier to do screening a little less frequently. One of the things I'm going to go through are what the guidelines say now. And I think that this is where we're going to talk about what needs to be adjusted. So under the age of 1, because there's a lack of predictability, the algorithm that we wrote had a lot of options for doing stimulation testing, which can be a lot of work. A lot of work for the endocrinologist, but more importantly, it's a lot of stress on families, having to do stimulation testing, coming back for multiple blood draws. And then starting at 1 year of age, when the sleep patterns are a little more predictable, trying to start everyone at 8 a.m. I think is helpful. But again, if you're getting these equivocal results, what to do and how often you need to stim is a little tricky. And then when to start treatment, whether it's stress or daily treatment, can also be difficult. So this is the original algorithm as it was published. I do want to point out that those newer assays, the cortisol levels have dropped. So most of the assays, a level of 10 is somewhere around 8.6. A level of 18, depending on the assay, will be roughly around 14.5 to 15. The ACTH values, as I said, there are no established levels for what's normal in anyone under the age of 3. And so these levels were based on best clinical estimates. And it's not unusual to see a newborn with an ACTH level that's hovering around 100. The question is whether that's going to then progress to being frank adrenal insufficiency or if it's going to normalize, and that can be very tricky. So what we had in terms of what's been published from newborn screening, there are a couple of publications out there that have come out of the states that have had it going on for a little bit longer. This is one from California, and what they're suggesting is that roughly around 20% of their babies are having evidence of at least biochemical evidence of adrenal insufficiency in the first 3+ years or so of life. And the other study that came out more recently, just in February, came out of Minnesota. And they're suggesting that the very long-chain fatty acids are on newborn screening may be predictive of who's likely to have adrenal insufficiency early. I want to emphasize this doesn't mean you're not going to have adrenal insufficiency, just they're suggesting that the higher levels are predicting earlier adrenal insufficiency. And this definitely contrasts with the diagnostic very long-chain fatty acids. So they published, this is a publication from just last month, and what they had 32 males who were identified by newborn screening. They had 7 who were identified as being symptomatic, 1 with only cerebral disease, 5 with only adrenal insufficiency, and 1 with both cerebral disease and adrenal insufficiency. And this is in the first 5 years of their newborn screening program. And what they were showing is that the kids who were in the pointer is lost a little bit. Oop. What they were showing is that the kids who were in this higher level, who had the higher levels of C26 LPC, were more likely to have symptoms in the first few years than the kids who had the lower levels. This does not mean that you're not going to go on to develop adrenal insufficiency. It's just they're saying that it seems like higher levels are predicting this in their population. And I want to emphasize that this does not mean that we should stop screening kids who are on the lower levels. So that's where we have information right now. I think that in the endocrine community, and when I've been speaking to people at centers who do see a lot of ALD, we all are feeling like maybe we need to revisit how often we're recommending stimulation testing, and also sharing some of our experiences where we've had kids who've had very high ACTH levels that then seem to normalize for several years. I've had kids that normalize and then go on to get adrenal insufficiency. I've had kids who are still sitting with normalized levels. And even the publication that I just showed you, when I spoke to the authors of that publication, they said one of the children seems like they're going into that normalized levels and not needing hydrocortisone, at least right now. So it's difficult to define adrenal insufficiency in a lot of these cases. And a lot of times when we have concerns that ACTH levels are high, we feel like it's a little safer to make sure the family has some stress dose hydrocortisone in case something comes up. But I think it's also important that we revisit in those kids who do seem to normalize whether or not we really need to continue giving the medication. I still think screening needs to continue, but I think that the case definitions sometimes change and we have to be flexible with that change, which is different than most newborn screening conditions that we deal with. It's either you have it or you don't have it, and ALD can be a tricky situation. So once we do have someone who clearly has adrenal insufficiency, what do we do? So the standard is the same standard that we have for any other child that we have in our office who has adrenal insufficiency for a different reason. We're going to give them hydrocortisone. Hydrocortisone is the preferred glucocorticoid to give, so there are other types of glucocorticoids. Hydrocortisone is the most rapid acting. It's the one that looks exactly like cortisol when you measure it in the blood. And it has the least impact on growth plates, which is really important when we're dealing with children who are growing. You give the dose typically either 2 to 3 times a day, depending on the child, the symptoms. And then stress dosing is given as needed, and family members do need to be trained how to do that. We'll go through that in a minute. Once glucocorticoid deficiency is identified, mineralocorticoid deficiency should be performed. Our guidelines say every 6 months for Pediatric Endocrine Society. The international guidelines, I think, say every 6 to 12 months. But if you do need treatment with that, that's also an oral medication that you take plus or minus some extra salt. And then for androgen deficiency in adrenal insufficiency, generally in academic endocrinology, we don't recommend replacement, but that is something that others will sometimes talk about. So what do we do once someone's on treatment? We need to monitor their growth. As pediatricians, that's our thing. And in endocrinology, it's definitely our thing to be monitoring. If a child's getting too much of the hydrocortisone, they're not going to grow well. If they're not getting enough, they're also not going to grow well. If you're giving too much, you need to be monitoring for Cushing's syndrome. That can be concerns for high blood pressure, extra weight gain. And that's also not good long-term because it can cause low bone mineral density and loss of muscle mass, which is really important long-term. And then anyone who's on hydrocortisone, I just always remind them, if you're starting a new medicine, please let your endocrinologist know, double check with your pharmacist, because other medicines do interfere with how it gets metabolized, and particularly a lot of the anti-seizure medications will tend to rev up the metabolism, so you may need a little bit extra when you get that. So anyone who needs stress dosing of hydrocortisone should have an emergency action plan. I always recommend that patients have a medical ID that says that they are steroid dependent. Like, I don't even use the word, you can say androgen insufficiency or adrenal insufficiency, but most important is I need steroids, because that just communicates very clearly in plain language what you need. They should have access to a 24-hour access to an endocrinologist. And then I recommend having kind of like a little go bag. It's like a little purse, a little backpack that has all the things that you need. It has your pills in it, it has your injectable, it has your emergency letter. Emergency plans for families. This is just one example of a publication, usually making it very clear, color-coded. It's like, this is what you do on a regular basis is your green, your yellow is you're sick at home, your red is you're sick and have to go to an emergency room. And then having a plan for surgery or anesthesia is important as well. This is a sample emergency letter that you can give to an emergency room or to a school nurse. And again, this is in a publication from the Pediatric Endocrine Society. And just to point out, having a plan ahead of time for anesthesia, for surgeries is really important. And this is a publication out of Minnesota with their anesthesiologist where they just said, hey, we had this many adrenal leukodystrophy patients with adrenal insufficiency. This was our plan, and we had no problems. And I think that's important. Adrenal insufficiency, a lot of times people will skirt by. I mentioned there was someone for 21 years who didn't have, it didn't have like a catastrophic event in that publication, but it just takes one catastrophic event to have a problem. So if you're prepared and you're treating, you should be able to avoid. So what do other ALD therapies do with adrenal insufficiency? Oh, I'm sorry, in the back. Yeah.
So you're saying that we're steroid.
So the question is, if they have adrenal insufficiency, they need steroids? Yes. I would say if someone has complete adrenal insufficiency, they should be on daily hydrocortisone. If someone has partial adrenal insufficiency, which this is where those interpretations and with the endocrinologist can come up, they should be on stress dosing. And so if they have an emergency situation, they get the influenza infection, they should be taking extra hydrocortisone in those situations.
About the carry dexamethasone, how could that work?
Dexamethasone works, yes. So dexamethasone is like your heavy hitter of the glucocorticoids. So dexamethasone is carried by paramedics because that's what you use to treat allergic reactions. But it absolutely works in the situation of an adrenal crisis. We prefer hydrocortisone for our patients with primary adrenal insufficiency because hydrocortisone has a little bit of mineralocorticoid activity. And you don't carry it, that's okay. But that's why we also have our families carry it. And that's why it's in our families' go bags, because then it can be administered by an emergency personnel. Now, every state has different rules about paramedics administering home meds, so I don't want to, I'm familiar with that, but if you get into the emergency room or if you're with a school nurse, they can use that in an emergency. Just a couple of statements about some of the other therapies that are out there. Lorenzo's oil is no longer here in the US. There was a very small open label study that was published suggesting that it might slow down the progression to adrenal insufficiency. I would caution interpretation of that study because it was a very small number of patients. It did not reverse adrenal insufficiency. Stem cell transplants, and gene therapy, which are used for the cerebral form of the disease, do not seem to alter adrenal insufficiency or reverse it. And then lastly, I just want to touch upon really quickly androgen deficiency and testicular dysfunction, because I think I'm a pediatrician, but I think this is really important for the adults with ALD. So there are very few studies, and most of these studies were published in the 90s when, first of all, our laboratory assays for hormone testing were not the greatest, but also I think we did not have as open of a culture of talking about things like this. So I think this is something that adult endocrinologists should really look into for men with ALD. But roughly about 3/4 of the men in the studies that are published had some form of androgen androgen deficiency, testicular dysfunction. And the thought is that very long chain fatty acids are interfering with how the testicles are making testosterone in similar ways that they interfere with the adrenal gland's ability to make glucocorticoids and androgens. And the big concerns with this are decreased bone mineral density, decreased muscle mass. It causes anemia, fatigue, depression, decreased libido, and this has real impacts on quality of life, and it's something that I think we need to understand a little bit better and understand when to start treatment, and it's a controversial area in endocrinology as well. So just to finish up, hopefully everyone has gotten from this that I think ALD screening is important for identifying those at high risk for adrenal insufficiency. I personally have not had any of my newborns have an adrenal crisis. If they've been identified by newborn screening, we have prevented some serious complications. Before newborn screening, adrenal crises happened. Kids probably went undetected with ALD and even had catastrophic events prior to newborn screening, so I think this is really important. Guidelines are attempting to account for these problems with measuring ACTH and the lack of diurnal rhythms for cortisol production in infancy, but I think we need to revisit how often we recommended doing stimulation testing and revisit what our recommendations are for treatment and classification, or have in the guidelines that it's okay to reclassify someone as you see the levels changing. And we really don't understand the natural time course still for the development, although I think we're starting to understand maybe who's at higher risk in those first couple of years. But again, I do not want to recommend anyone changes screening or not screen based on how high those levels are. I think at this time we really need to screen. And lastly, as I mentioned, I think adult studies are really needed to understand testicular dysfunction. And as I mentioned, I think guidelines, the next steps are really rewriting guidelines to account for these changes in cortisol assays, recommending fewer stimulation tests, and then really having a consensus about what to do with kids who have these borderline ACTH levels. And then for the adults, as I mentioned, not only testicular dysfunction, but I think bone health is another endocrine issue, needs to be looked at. Like adults need to have DEXA scans likely, deciding when to start them on medications that are going to help with bone health, particularly if they're not ambulatory, I think is important. And then understanding better the females, which I think that talk is coming a little bit later, what's going on with their adrenal function is important. And I just want to thank everyone in this room, particularly Miranda and Elisa. I really appreciate everything that you guys have done, and I'm happy to take any questions. Yes.
I was just curious about who said that stem cell transplant doesn't have an alignment with whether or not somebody's going to develop full adrenal insufficiency. And I was just curious, because my son, when he went into transplant, had a slightly elevated ACTH, but a very reassuring morning cortisol. Went into transplant, and 2 months later, he was full-on adrenal insufficiency. I was just curious about that. That was my first question. And then my second question was, do parents give you any feedback on where at the school they're keeping their medications? We had an unfortunate circumstance of a lockdown this year at my son's school, and it just occurred to me that in that circumstance he did not have access to his medication. So we've now made arrangements so that his teacher has it as well as the school nurse. I was just curious if any feedback is.
Yeah. So the first question was related to stem cell transplant and adrenal insufficiency. There's no evidence that that alters when you will get adrenal insufficiency. The one thing I would just say is a lot of times with transplant medicine, kids end up on high doses of steroid medications when they're getting their transplants. That negative feedback from the outside steroid can suppress what amount of cortisol, the normal amount of cortisol you're making in anyone, whether they have ALD or not. And if that steroid is abruptly stopped, it can take time for your own cortisol to recover, but you may have, for any boy with ALD, they may have just been progressing and not making more cortisol during that time as well. So it's a little tricky with if you've been getting steroids for another reason. And then the other question is about school and emergency planning. And it is tricky, and every school and every state has different laws, and hydrocortisone injections require a needle to be with them. I have this issue also with my patients who have type 1 diabetes, which is, and there are, every school district in New York, I don't know about everywhere else in the country, has a different policy for how they handle this. I am happy always to write a letter that it should be in the classroom in case of a lockdown situation, because unfortunately we're now living in a situation where kids do have these situations come up and they do have lockdowns and they don't have access to their nurse or their medications. So I do try to encourage that there's just like a bag that just kind of goes with you wherever, whether it's adrenal insufficiency or diabetes. But some schools have different rules, so I can't always fix that. But yes, that is something that is real that we think about too. Any other questions? Yes.
The chat.
Oh.
Okay, good morning. We just have two things from the chat. One is a very appreciative parent for the slides that you shared about the treatment plans for good days, bad days, surgery, just asking if they can have access to those. So I said we
yes,
maybe
so it's a publication. Hold on one second. It's actually, let me see, I think I can go back. So Brad Miller from Minnesota is the first author on that publication. It also has the sample emergency letter on it. It's called Emergency Management of Adrenal Insufficiency in Children, Advocating for Treatment Options in Outpatient and Field Settings.
Okay, thank you.
And it's at the very bottom of the slide, and I'm pretty sure it's open access so that you can then go in and just take the pictures out of it.
Thank you. And we'll make sure that we send that off also. And then there's a question, I'm just going to read it. I would like to inquire about the use of circadian rhythm-based dosing, in parentheses, every 6 hours, and its effectiveness in managing adrenal insufficiency. Has there been any research or clinical evidence supporting its benefits for adrenal insufficiency patients?
So this is a loaded question in the endocrine community. Usually, I would say most people agree not every 6 hours, with the exception of stress dosing. Stress dosing is different. Your body, you can, if you're stressed, you have fever, you're having surgery, it doesn't matter what time of day, your cortisol levels should be up. The Endocrine Society has a statement looking at how frequently to dose hydrocortisone, and they offer two options. One is, and all of them have highest dose in the morning, which is trying to mimic that 8 a.m. peak that you have, but we're never perfect at that because you would have to basically have it starting while you're still asleep and about to wake up. And then giving the lower dose either like early afternoon if it's 2 doses, or if it's 3 doses, a dose at lunchtime and a dose like sort of in that late afternoon period. And the idea is that you should not have a lot of hydrocortisone on board as you're going to sleep so that it's lowest at nighttime. There are studies using insulin pumps and giving hydrocortisone under the skin and trying to make that a rhythm. There are newer drugs that are either in development or about to be approved where they have slow release hydrocortisone. So like you get a fast release in the morning and then slow release during the day, so that it's trying to mimic the normal circadian rhythm. So people are thinking about it in terms of what that looks like for blood pressure, blood sugar. There's hard, the evidence is not so strong for any of these things, and it's hard because everyone's an individual. Everyone has different sleep patterns and wake patterns and eating patterns, and what works for one child doesn't work for another. And especially as people get to adulthood and they're working shifts and doing other things, you have to really customize it for whatever the child needs. I hope that answers the question, but people do look at bone health, growth outcomes. That's why we know hydrocortisone better than other steroids. But I don't know if there's any one plan that's proven to be better than another. Any other questions? Thank you.